Your skin is screaming. 6 rashes that signal. Internal disease. Every single day, millions of people look in the mirror and see something that wasn't there yesterday. A red patch, a cluster of small bumps, a spreading rash that appeared overnight. And their first thought is always the same. Allergic reaction, something I ate, maybe the new detergent. They apply a cream, take an antihistamine, and wait for it to disappear. But in approximately 15% of those cases, that rash is not an allergic reaction at all. It is an alarm system. It is your largest organ, your skin, broadcasting a distress signal from somewhere deep inside your body, and ignoring that signal can cost you years of your life. I have spent 15 years in clinical practice, and I can tell you with absolute certainty that your skin is not a separate system. It is a display screen. When your liver is failing, your skin shows it. When your kidneys are struggling, your skin announces it. When your immune system is attacking your own tissues, your skin reveals it long before you feel a single internal symptom. The problem is that most people, and unfortunately most doctors in a 12-minute appointment, see only the rash. They treat the symptom. They prescribe a topical steroid, send you home, and never ask the question that could save your life. What is happening inside your body that is forcing your skin to scream? Subscribe to Dr. Waterling right now and hit that like button. We're working toward building this channel on one principle. The healthcare system will not tell you what your body is trying to say because there is no billing code for prevention. There is no revenue model in teaching you to read your own warning signs. So we are doing it here, and every subscriber moves us closer to reaching the people who need this information before it's too late. Let me tell you about Margaret. She was 58 years old when she walked into my office. She had a rash on her shins. Both legs, symmetrical, small red-brown bumps that had been there for 3 months. She had been to 2 dermatologists. One told her it was eczema. The other said it might be an insect bite reaction. Both prescribed steroid creams. Neither cream worked. When I examined her, I recognized the pattern immediately. The rash had a specific name, necrobiosis lipoidica, and it does not appear because of allergies or insect bites. It appears because the small blood vessels in the skin are being destroyed by chronically elevated blood sugar. Margaret did not know she was diabetic. Her last physical exam had been 4 years earlier, but her skin knew. Her skin had been screaming for 3 months. When we ran the blood work, her hemoglobin A1C was 9%, well into the diabetic range. She had been walking around with uncontrolled diabetes, damaging her kidneys, her eyes, her nerves, while 2 doctors treated her rash with moisturizer. That is what I mean when I say your skin is screaming. It is not being dramatic. It is being literal. And today, I am going to walk you through 6 specific rashes that are not what they appear to be. These are not skin problems. They are internal warnings. Some of them signal liver disease. Some point to autoimmune conditions. One of them is an early indicator of certain cancers. And all of them are missed, dismissed, or misdiagnosed thousands of times every single day because the person looking at them does not understand what they are seeing. Now, before we go further, I need to be direct with you. If you have a rash that is spreading rapidly, covering large areas of your body within hours, if you have a rash accompanied by fever, difficulty breathing, swelling of your lips or tongue, or if you have a rash that forms blisters and the skin is peeling off in sheets, that is a medical emergency. That could be Stevens-Johnson syndrome, toxic epidermal necrolysis, or anaphylaxis. You do not search for videos. You call emergency services immediately. What I am discussing today are chronic, persistent rashes that appear gradually and stick around. The ones that get dismissed as minor skin irritations when they are actually broadcasting critical internal information. Let's start with the liver. Your liver is a chemical processing plant. It filters toxins, produces proteins, stores energy, and manages hundreds of metabolic functions every single second. When it starts to fail, it cannot announce the problem with pain because the liver has almost no pain receptors. So it uses your skin, and one of the earliest visible signs of liver dysfunction is a condition called xanthelasma. These are small, yellowish, flat plaques that appear on the eyelids, usually near the inner corners. Most people think they are fat deposits, cosmetic annoyances, and technically, they are cholesterol deposits. But the question is, why is cholesterol depositing in your eyelids? The answer is that your liver has lost its ability to process lipids correctly. When the liver cannot metabolize cholesterol and triglycerides efficiently, these fats start accumulating in places they should not be. Your eyelids are one of those places, but the eyelids are just the visible announcement. The real problem is happening inside. If you have xanthelasma and you are over 50, there is approximately a 50% chance you also have significantly elevated cholesterol levels, fatty liver disease, or early cirrhosis. The plaques on your eyelids are not the disease. They are the signal. And if you remove them surgically without addressing the liver dysfunction causing them, they will come back. I have seen patients spend thousands of dollars on cosmetic removal procedures, only to watch the plaques reappear within months because nobody treated the underlying metabolic collapse. Now let's talk about the kidneys. Your kidneys filter roughly 180 liters of blood every single day. They remove waste products, balance electrolytes, regulate blood pressure, and control red blood cell production. When they start to fail, they do it quietly. Kidney disease is called a silent killer because you can lose 70% of your kidney function before you feel anything wrong, but your skin will show it much earlier. And the rash that announces kidney failure is called uremic frost. But before it gets to that extreme stage, you will see something else: intense, unrelenting itching without a visible rash, or a rash called acquired perforating dermatosis. This rash appears as small, hard bumps, often on the arms and legs, with a central core that looks like a tiny crater. The bumps are not infected. They are not insect bites. They are your skin trying to push waste products out through the surface because your kidneys cannot eliminate them through urine anymore. When the kidneys fail, toxins called uremic compounds build up in the bloodstream. Your body, in a desperate attempt to get rid of them, starts depositing them in the skin. The itching is unbearable. Patients scratch until they bleed. Antihistamines do not work. Steroid creams do not work, because the problem is not in the skin. The problem is in the blood. And if you are experiencing severe itching, especially at night, with or without a rash, and you are over 60, you need a kidney function test immediately. A simple blood test measuring creatinine and glomerular filtration rate will tell you if your kidneys are failing. Catching it early can slow the progression. Ignoring it leads to dialysis. Here is the third one. And this is the one that terrifies me the most because it is associated with malignancy. It is called acanthosis nigricans. This presents as dark, thick, velvety patches of skin, usually in body folds, the neck, armpits, groin, under the breasts. Most people think it is dirt. I have had patients come in and tell me they have been scrubbing their neck every day, sometimes with harsh exfoliants, trying to wash it off. But it does not wash off because it is not dirt. It is a skin response to insulin resistance, or, in more sinister cases, internal cancer. When acanthosis nigricans appears suddenly in an adult who was not previously overweight and who does not have diabetes, it can be a paraneoplastic syndrome. That means it is caused by a tumor, most commonly gastric cancer, but also lung, liver, or ovarian cancer. The tumor produces growth factors that stimulate the skin cells to multiply abnormally, creating that thick, dark appearance. It is called malignant acanthosis nigricans, and it is one of the few skin signs that can appear before the cancer causes any other symptoms. I saw this in a 62-year-old man who came in complaining about dark skin on his neck that had appeared over 3 months. He had no other symptoms. No weight loss, no abdominal pain, no digestive issues. But when we ran imaging studies based on the rash alone, we found a gastric tumor. Because we caught it early, based purely on the skin finding, he had surgical options. If he had waited until he developed abdominal symptoms, the cancer would have been much more advanced. Now, not all acanthosis nigricans means cancer. In most cases, Especially in people who are overweight or have metabolic syndrome, it signals severe insulin resistance, which is the precursor to type 2 diabetes. But here is what you need to understand. If you develop these dark patches and you are not overweight, or if they appear suddenly rather than gradually, that requires immediate medical investigation, including cancer screening. Do not let a doctor dismiss it as a cosmetic issue. Demand a full workup. The fourth rash is called dermatomyositis, and it announces an autoimmune attack on your muscles. The classic sign is a purplish-red rash on the eyelids, often described as a heliotrope rash because it has the color of the heliotrope flower. You will also see red scaly patches over the knuckles, called Gottron papules. These are not eczema, they are not contact dermatitis, they are the visible markers of an immune system that has started attacking your own muscle tissue. Dermatomyositis causes progressive muscle weakness. It usually starts in the muscles closest to the trunk, the hips, thighs, shoulders, and upper arms. People notice they have trouble climbing stairs, getting out of a chair, or lifting objects overhead, but the rash appears first, sometimes months before the muscle weakness becomes obvious. And here is the critical part. In adults over 50, dermatomyositis is associated with an increased risk of underlying malignancy, particularly ovarian, lung, and colon cancer. Approximately 15 to 25% of adults diagnosed with dermatomyositis have an associated cancer. That means if you develop this rash, you need not only treatment for the autoimmune condition, but also comprehensive cancer screening. The treatment for dermatomyositis typically involves corticosteroids and immunosuppressive drugs to calm the immune attack. But without diagnosis, the muscle damage progresses, leading to severe disability. I have seen patients who were told their rash was a sun allergy or rosacea, who went months without proper diagnosis while their muscles deteriorated. By the time someone recognized what they were looking at, the muscle damage was extensive. Early recognition saves function. Number 5 is erythema nodosum, and this one signals inflammation somewhere deep in your body. Erythema nodosum appears as painful, red, raised nodules, usually on the shins, sometimes on the forearms. The nodules are tender to touch, warm, and they appear suddenly, often in clusters. They look like deep bruises, but they are not caused by trauma. They are caused by inflammation of the fat layer under the skin, triggered by an immune response to an underlying condition. The list of conditions that cause erythema nodosum is extensive. Streptococcal infections, tuberculosis, sarcoidosis, inflammatory bowel disease, particularly Crohn's disease and ulcerative colitis, certain medications including antibiotics and birth control pills, and in some cases, lymphoma. What this means is that erythema nodosum is never a primary skin disease. It is always secondary to something else. Your body is fighting something, an infection, an autoimmune process, a malignancy, and the fight is manifesting on your shins. When someone presents with erythema nodosum, the diagnostic workup is extensive because you have to find the trigger. Chest x-ray to check for sarcoidosis or tuberculosis. Throat culture to rule out strep. Colonoscopy if there are any digestive symptoms to check for inflammatory bowel disease. Blood work to look for signs of infection or inflammation. The nodules themselves will resolve on their own over several weeks, but if you do not identify and treat the underlying cause, they will keep coming back. And more importantly, the underlying disease will continue progressing untreated. The sixth and final rash I want you to understand is called pyoderma gangrenosum, and this is one of the most misdiagnosed conditions in dermatology. It starts as a small pustule or red bump, often mistaken for an infected insect bite or a boil. But instead of healing, it rapidly breaks down into a painful ulcer with a distinctive appearance. Purplish, undermined edges that look like the skin is melting away from the center, and a base that may be covered with pus or dead tissue. It looks infected, but it is not. Culturing the wound will not grow bacteria. Antibiotics will not help. In fact, surgical debridement, which is the standard treatment for most ulcers, makes pyoderma gangrenosum worse. Cutting into it causes it to spread. Pyoderma gangrenosum is associated with systemic inflammatory diseases, most commonly ulcerative colitis, Crohn's disease, rheumatoid arthritis, and certain blood disorders including leukemia. Approximately 50% of people with pyoderma gangrenosum have an associated systemic disease. The ulcers are not caused by infection, they are caused by abnormal immune activity, neutrophils attacking the skin tissue for reasons that are not entirely understood. The treatment is immunosuppression, high-dose corticosteroids, drugs like cyclosporin or biologics that calm the immune system. But here is the tragedy. I have seen patients with pyoderma gangrenosum who spent months being treated for infected wounds. They were given antibiotic after antibiotic. They underwent wound debridement. The ulcers got bigger. The pain got worse. And nobody recognized what they were looking at because pyoderma gangrenosum is rare. And unless you have seen it before, it looks like 100 other things. One patient came to me after 8 months of failed treatment. She had an ulcer on her leg the size of my palm. She was in constant pain. When I recognized the pattern and started her on prednisone, the ulcer began healing within a week. Within 6 weeks, it was completely closed. 8 months of suffering ended with the right diagnosis. Now, how old are you? Write it in the comments. I want to see which age group makes up the majority of our viewers because it will directly shape what I cover in future videos. The patterns I am describing today appear predominantly in adults over 50, but some of them occur in younger people as well, and knowing your age distribution helps me prioritize content. Here is what I need you to understand. Your skin is not a cosmetic organ, it is a diagnostic tool. When something appears on your skin that was not there before, especially if it persists for more than 2 weeks despite treatment, you must ask the question, what is my body trying to tell me? A rash is not always a rash. Sometimes it is a liver that cannot process fats. Sometimes it is kidneys that cannot filter toxins. Sometimes it is an immune system attacking your muscles. Sometimes it is a tumor announcing itself months before it causes pain. The healthcare system will not tell you this because there is no revenue in teaching you to recognize warning signs early. There is profit in advanced disease, in expensive treatments, in procedures that could have been avoided if someone had paid attention to the skin 6 months earlier. I am telling you this because I have watched too many people suffer needlessly, treated for the wrong thing, given creams and ointments and reassurances when what they needed was a kidney function test or a cancer screening or an autoimmune panel. If you take nothing else from this video, take this. If you have a persistent rash, especially if you are over 50, and especially if it does not respond to standard treatments, insist on a full medical workup, not just a dermatology referral, a comprehensive internal medicine evaluation, blood work including liver enzymes, kidney function, blood sugar, inflammatory markers, and lipid panel, imaging if there is any suspicion of internal disease, and if your doctor dismisses your concerns, find another doctor. Your skin is screaming. Someone needs to listen. Subscribe to Dr. Waterling and help us reach more people with this information. Share this video with someone you care about, a parent, a friend, someone who might be ignoring a signal right now that they do not understand. You may have just given them a real chance to catch something early. The system makes money when you stay sick, not when you get better. But we are building something different here. One video at a time, one subscriber at a time, giving people the knowledge they need to save their own lives.